My topic is all about efficacy of chlorhexidine over povidone iodine as preoperative antiseptic in reducing the risk for surgical site infections. According to the CDC, surgical site infections are the most common healthcare-associated infection. Let's define what surgical site infection is. This is an infection of the tissues, organs, or spaces exposed by surgeons during performance of an invasive procedure. Infection occurs up to 30 days after surgery or up to 1 year after surgery in patients receiving implants, affecting either the incision or deep tissue at the operation site. The common cause of it is the contamination of the wound with patient's normal skin flora. The logical step is to eliminate or minimize the skin's natural flora at the time of surgical antisepsis in preventing contamination and infection during surgery. Hospital-acquired infection is most common within 31 to 38%. This occurs to 5% of patients undergoing surgery. 1 in 24 patients who undergo inpatient surgery in the United States has a postoperative SSI. These SSI develop in 2 to 5% of more than 30 million patients undergoing surgical procedures each year. Let's talk about the impact of SSI. SSI are associated with substantial morbidity and mortality, prolonged hospital stay, and increased cost of hospitalization. Among patients dying in the postoperative period, 75 cases of SSI is death-related. In one case-controlled study using orthopedic patients, SSI led to median increase in the hospital stay for about 14 days, twice increase in the rate of rehospitalization, increased total costs above 300%. There are two surgical antiseptics that is being used in this study. You have your povidone iodine and chlorhexidine. Povidone iodine has its own disadvantages. This includes skin irritation, problems with allergic reaction, similar to patients with shellfish, seafood allergies. The drying time is almost 3 minutes. Povidone iodine is compared to chlorhexidine, high solubility in water, economical and effective in eliminating broad-spectrum bacteria, while chlorhexidine, more rapid onset of action and persistent antiseptic effect, it's up to 48 hours. The broad-spectrum activity including HIV. It is noteworthy that a number of recent published articles compared the effectiveness of chlorhexidine with povidone iodine. For instance, its effectiveness in clean contaminated surgeries, that is according to Naorani et al. We have substantive effect or residual effect following absorption in the skin, that is according to Mashas et al. According to Edmiston, risk reduction properties on infection following a full skin surface cleansing if administered. Then according to Lee et al., pharmacoeconomics and or cost effectiveness as compared with iodine and other iodophores. You have also chlorhexidine for adult population. Example, antiseptic in children can cause skin burns in infants, neurotoxicity in preterm babies, and presence of the substance on the bloodstream among infants. Unidentified best method of preparation of chlorhexidine in preventing surgical site infections. The statement of the problem was formulated using the Johns Hopkins Nursing Evidence-Based Practice Question Development Tool. As a guide for the researcher, the tool has 9 questions which enhances the researcher's capacity to develop and focuses on the problem, guide the researcher in the development of PICO questions, and enhances clinical questions. We have the PICO questions you have here. patients undergoing surgery. I, chlorhexidine as preoperative antiseptic. Then we have the comparison or the control of povidone iodine as preoperative antiseptic. Outcome, incidence of postoperative surgical site infection. The research problem of our study is chlorhexidine a better antiseptic than povidone iodine in the reduction of surgical site infections when administered preoperatively? In the view of evidence, an electronic research was conducted. Last April 2017, we have EBSCOHOS, Science Direct, and Clinical Keys. This used to review the available literature fitting the topic of interest. We have also the mesh terms. We have your chlorhexidine or chlorhexidine gluconate and iodine or povidone and surgical site infections or preoperative antiseptic or preoperative skin antisepsis or preoperative cleansing. Limiters were applied to the three databases. This is limited to journals. We have January 2000 up to April 2017 on English language. This is being peer-reviewed and full-text articles. The references that was used is eligible in studies. We have the different issues. We have your abstract forms. Some are purchasable. Manual screening of duplicate studies was performed. Furthermore, single studies that are included in systemic reviews or meta-analysis were excluded. The articles that selected for analysis in the review met the following criteria. Looking at the table, we have the inclusion and exclusion that were due to the following reason. In the data extraction, information from selected studies was extracted. This includes using your piloted data forms. We have author, date, funding agency. You have the population, intervention, control treatment, the outcome, critical appraisal or strength, and the level of evidence. Studies eligible for analysis that are systematic with review and meta-analysis were scored using the Amstar measurement tool. We have the checklist that contains 11 elements, such as assessing the comprehensiveness of the literature search, inclusion and assessment of bias. The checklist has 4 criteria. We have the yes, no, not applicable, can't answer, and a note in italic font after every question to instruct the assessor on what criteria or assessment he or she should be looking for in the article. Extracted data were entered into the comprehensive meta-analysis software. For studies selected involving systemic reviews, the summary effect reported in the risk ratio or odds ratio. We have the class interval and confidence interval was used for the analysis. The comprehensive meta-analysis software program, you have your standard chi-square and total observed variation, were used to assess heterogeneity, which was the basis for selecting the fixed effect model, and the funnel plot was used to assess for the publication bias. In the review of evidence, a total of 1,115 studies from the 3 search databases were obtained during the initial search. 2 research articles were obtained from alternate means. A total of 87 were identified as relevant studies on the topic of interest. After applying all the exclusion criteria, 6 studies were retained, which were subjected to the quality assessment. Thus, 4 studies were eligible for analysis. Table 1 summarizes the steps in reviewing the evidence. All four studies compared chlorhexidine versus povidone iodine in presenting and decreasing SSI as one of their outcome of interest and did meta-analysis on the outcome. 1. Included gray literature. 2. Included studies in Asia. 2. Included studies beginning in 1980s, in which 2 included 2000 up to 2016. All use rating scale for quality assessment. 1 excluded bathing, soaking, and gargle of chlorhexidine before operation. All are meta-analysis and systematic review. All four literature use quality appraisal tools such as grade, jotted, and combining elements from 2 scales. The concentration of chlorhexidine methods of preparation vary from each study selection. You have 2% to 4% chlorhexidine in alcohol, 0.5% to 1.5% concentration in 70% alcohol. Summary of studies included in the review. You have your study 1. Chlorhexidine alcohol versus povidone iodine for preoperative skin preparation. A systemic review and meta-analysis. In study 2, we have your systemic review and meta-analysis of preoperative antisepsis with chlorhexidine versus povidone iodine in clean contaminated surgery. The third study, systemic review and cost analysis comparing the use of chlorhexidine with the use of iodine for preoperative skin antisepsis to prevent surgical site infections. And the last study, skin antiseptics with chlorhexidine versus iodine for the prevention of surgical site infection. Figure 1 talks about the forest plot of chlorhexidine versus iodine comparing the incidence of SSI. A total of 26 studies, 12,294 participants were involved in the analysis. The outcome of interest is the reduction of surgical site infection. The left side of the forest plot favors chlorhexidine, while the right side favors iodine. As gleaned from Figure 1, all the 4 studies entered for analysis are on the left side of the forest plot, which favors chlorhexidine. Similarly, the pooled effects favor chlorhexidine than iodine in reducing SSI when administered preoperatively. In Figure 2, you have now the assessment of heterogeneity. By visual inspection of the funnel plot, there is no significant evidence of heterogeneity. These dispersions may suggest that there is less variation based on within-study error. Similarly, the total observed variation is 0.000, thus the possibility all of the dispersion is be attributed to random error. As seen in Figure 3, in the assessment of publication bias, there is no presence of publication bias as studies are distributed symmetrically. There is possibility that bias did not occur since the 4 studies reviewed polled higher samples. Surgical site infection can affect the quality of care, increase the mortality rate in after-surgical procedure. Preoperative antiseptic solution decreases pathogens in the skin surface around the incision, indicating the type of skin antiseptic preparation against infection and contamination of the wound. The most commonly used antiseptics are chlorhexidine and povidone iodine. However, this antiseptic solution of both agents are strengthened with alcohol to prevent post-operative wound infection. This study was performed in order to analyze existing RCTs for evidence concerning the relative effectiveness of chlorhexidine versus povidone iodine in preventing surgical site infection. There are some limitations of the study. First, there is a high heterogeneity of the studies included. Some of these are the variations in the method and duration in which the antiseptic solution was applied on the skin. Some use scrubbing versus painting. Second, the chlorhexidine povidone iodine varied according to its antiseptic concentration, taking into consideration that there is no evidence to suggest that varying the concentration of chlorhexidine or povidone iodine could improve the efficacy of the antiseptic agents. Third, some studies did not define the definition of surgical site infection. The authors incidentally found out the presence of SSI from the study results. Fourth, the study focused only on chlorhexidine versus povidone iodine without including agents combining povidone and alcohol such as benzalkonium chloride. The last, we have to take into account the factors associated with choosing the skin antiseptic skin agent, such as patients' allergies, the skin condition, and environmental risks are also taken into account. In conclusion, iodine is still widely used as the most common preoperative antisepsis. EBP review on the two antiseptics favors chlorhexidine over iodine in the prevention of SSI. Chlorhexidine, when used preparatively, not only decreases the risk of SSI, but it also becomes beneficial to the patient in the hospital. There may be differences in the concentration, application, and type of surgery it would be used, yet the majority of the studies indicate that lesser events of SSI have occurred to chlorhexidine as compared to iodine. Potential bias to the review and cannot be avoided, but by looking at the scientific merits of its sound methodology and substantial findings, it is indeed necessary to pilot test the intervention. Our recommendations, according to Parsley and Corrigan, whenever new evidence is discovered, it must be acted upon through planning. Moreover, monitoring the plan will help determine whether it is contextually suited or effective for practice. The researcher made an action plan using the Johns Hopkins ABP model as recommendation for the next phases of the study should it undergo a full ABP study. The plan includes project description, objective setting, and necessary personnel and implementation. An intervention timeline guided by the PET, Model Johns Hopkins Project Management Guide, and Evidence Adoption Assessment Plan.